So welcome all. Thank you for being here. My name is Brooks Roach. I am a diabetes education specialist with Diabetes Canada. And I'd like to begin by acknowledging that I'm joining from the traditional and unceded territory of the Mi'kmaq people. And I invite you as a viewer to take a moment to reflect on the land on which we live and acknowledge the past inhabitants of what we now call Canada. We are here today for a really exciting conversation to talk about virtual care, what it means, why it's important, and specifically how it impacts people living with type 2 diabetes. So we are joined today, I have the great privilege of having some wonderful guests, Dr. Ilana Halperin, who is an endocrinologist and assistant professor at Sunnybrook Health Sciences Center and the University of Toronto, Department of Medicine's Division of Endocrinology and Metabolism. Welcome, Ilana.
Thanks so much.
Thank you. I never know how to do that either, the intro, it's all good. Dr. Tara Kiran, who is a family physician at St. Michael's Hospital and the Fidani Chair of Improvement and Innovation at the University of Toronto. Welcome, Tara.
Hi.
And we also have Maria Smith-Williams, who is a healthy lifestyle advocate and certified personal trainer who lives with type 2 diabetes. Welcome, Maria.
Hi, everyone.
Hi. So thank you so much to the three of you for being here. I'm super excited to have you all here and have this wonderful, diverse range of perspectives that you're all going to bring to this discussion. So today, our experts will be answering some key questions that they have been hearing from patients and other folks who live with type 2 diabetes. And they're also going to be taking some questions from you, our viewers. So some have been already submitted, and you can ask your questions if you're viewing on Facebook Live by just posting in the comments section. And you can do this at any point through the webinar if a question strikes you, and we'll answer it during a Q&A section toward the end. So with that, let's dive right into what's sure to be a great conversation. And we're going to start with Dr. Halperin with a question as follows. So I'm wondering if you can walk us through the impact that the COVID-19 pandemic has had on individuals with type 2 diabetes and their quality of care.
Yeah, it's a fantastic question. And obviously we're 18 months in almost of living with COVID-19 in our midst. And I think we have to start by recognizing that people with diabetes are people like all other Canadians. And so a lot of the same stressors that have been happening for everyone else have been happening for them. And Diabetes Canada actually did two surveys, once in May and June of 2020, and then again in 2021. And the themes were similar. So many people living with diabetes, were worried about the fear of contracting COVID-19, struggling with the mental health burden of being isolated from friends and family, feelings of loneliness. And a substantial minority of the survey respondents did have financial difficulties during the pandemic, possible loss of job and inability to pay for medications and diabetes monitoring devices, which made managing their diabetes more difficult. But we also know that as virtual care goes, diabetes actually lends itself pretty well, and that a lot of people had virtual visits, primarily by phone, a little bit by video. Across Canada, the majority of the respondents to the survey were very happy with their virtual care and hope that virtual care continues to be an option for people living with diabetes well after the need for physical distancing is behind us, which we all hope is sooner rather than later. And we can get more into some of the details around different ways that you can share your data with your healthcare professional and all of that, but I'll stop there for now and see what else comes up in the Q&A.
Thank you, Ilana. The next question I'd like to direct to both Maria and Dr. Kiran, and I'm wondering if you can each share sort of each side of the story, and this is around what has it been like at the individual level to both treat and live with diabetes over the course of this pandemic. Maybe we can start with Maria.
Well, we all know that living with diabetes at the best of times is challenging, much less during a pandemic. I've been living now with diabetes for 8 years. I was diagnosed in my early 40s. And I found that during this pandemic, I've had to become creative in the way that I stay active and I manage my blood sugars, especially since the gyms are closed. We're all working from home, and all the mental stress that is happening around, the fear of contracting COVID and not seeing your family. At one point, I reached the point where I was exercising with my neighbors on my driveway just to stay motivated and keep active. So it's been pretty good though. I've kind of stayed to a regimen that I established for myself a long time ago, and it's worked out pretty well for me.
It's great to hear about that, Maria, and how your own life has changed. I mean, I think from my perspective as a family doctor, of course, we're seeing just a snippet of people's lives when they come in and check in with us. And during that time, we really are focused on trying to make sure that we're helping them to do everything possible to keep themselves healthy. So mentally and physically well, and then also get all kind of the testing that helps us to monitor whether the diabetes has started to affect other organs in their body, whether that be the heart, or and how we can continue ensure that they have keep a healthy heart, or the feet or the eyes, etc. And so, really early on in COVID, I worked with a group of colleagues to try and figure out how can we support family doctors and provide guidance to family doctors about this switch to virtual care to ensure that diabetes care doesn't just fall off the radar, because now we're not seeing as many people in person, and in-person care, of course, carries risk. Because at that time, we even early on knew that if you had diabetes, you were at higher risk of getting COVID complications. And so we wanted to avoid exposing people to in-person visits and potential COVID exposure that goes along with coming in person, whether that be through the transportation, taking the public transport, or seeing people in the waiting room, or seeing ourselves. And so we wanted to avoid people having to come in, but still ensure that they were getting the care they needed. And I think this was actually a really good opportunity for us to take a new lens, a fresh lens on, what it is that the provider really needed to do, what could now be done by the patient effectively with some coaching, and really kind of put together a new schedule. Because we kind of had this process of trying to see people every 3 months and going through a checklist of things with them. So now, what we said is, if people have well-controlled diabetes, probably a lot of those 3 monthly visits could happen on the phone. And probably at minimum, you need a once a year in-person check-in. Now, of course, if someone's diabetes is not as well controlled, or they're having a harder time engaging on the phone because of language issues, hearing issues, access to technology, those are reasons to have them come in so that they, don't miss care. But for the vast majority of people, a lot can be done virtually. And one of the things that I really shifted to in the pandemic was supporting people to do more self-assessment at home. And so in particular, 2 areas. One was high blood pressure. So we always try and screen for that in the office using our own high blood pressure machine. But instead, many patients felt that they were able to afford to go out and buy one. Others who weren't able to afford it, sometimes their plans would cover it, including the public plan. People who are in social assistance in Ontario, that plan started to cover it as well. So getting people the tools to do their blood pressure monitoring at home instead of having to bring them in for that. The other piece was foot exams. So we're really accustomed to doing a very specific kind of foot exam in the office to ensure that people don't have damage to their nerves, and that their skin and blood flow is healthy. And we realized that actually there are tools out there that teach people how to do those things at home. And so we put together, a tool for physicians to say, these are kind of handouts that you can use for patients to help them measure their own blood pressure, to help them check their own feet. And then, of course, we are always trying to encourage and empower people around self-management. And the reason, and there was even more reason to do that now. So and then I guess the last thing I'd say is, like, we rethought what the intervals really needed to be for some forms of testing. So do people really need to go and get their blood work every 3 months? Or can it be deferred for 6 months or 9 months? And then when we do it, let's be more strategic. Let's take a little bit more time to make sure we're getting all the things we need during that one time, so that we don't have to have them go back and repeat that blood work, because every trip to the lab has some risk. Does everyone really need to have that eye exam at 1 year? Now, some people absolutely do need to have an eye exam every year, but perhaps there's some people who are really well controlled who don't need to have that eye exam every year. So I think that's the other piece, is really thinking about what needs to be done. So empowering patients and thinking differently about what needs to be done.
Now, I'll just add two things to that that I think are interesting, is that, I really spoke even before the pandemic about this idea of a 3-to-1 ratio where, 3 visits over the phone or video to 1 in person. One thing that I think we've been challenged with now is that the pandemic has gone on for more than a year, and there are some people who are still somewhat frightened to come and see their healthcare providers, or will tell us that their healthcare providers are still not open to see them. And that's obviously something that I think we really are struggling with, because now it's like, if you didn't have that home blood pressure monitor, you haven't been to the lab in more than a year, or you haven't had your feet checked by a professional in more than a year, and you have some symptoms or concerns, it really is important not to delay that care anymore, that the risk of delaying that care probably is worse than the risk of contracting COVID, given the high rates of vaccination and our good access to personal protective equipment, everybody's masks in the encounter, et cetera, et cetera. So I do think, I've had a few of those experiences where someone didn't go to the lab for more than a year and their kidney function declined really significantly over that time. And so obviously there's that balance, and I'm definitely a fan of choosing wisely when we send people, but a year is too long. So if you're watching this and you haven't seen your doctor in a year or had blood work in more than a year, I'd really urge you to do that.
Well, I have to say that I was one of those people that had not been to the doctor for a year. But in my defense, I would like to say that my blood sugars were pretty good. So even though it had been that year and I was too afraid to go to the lab, I had a really good GP, and he kept on me about the numbers. And yeah, but when I went, everything was good.
No, and that's a really good point, Maria, that I think Dr. Kiran specifically didn't bring up, which is the blood glucose monitoring, which I'll probably get into in Brooke's next question. But it is true that when it comes to the glucose monitoring, that was the thing I was actually less concerned about people going to the lab for. I didn't really care about that A1C test if they were monitoring their glucose regularly. Yeah. But it's the other things we're monitoring for as well, like kidney function, et cetera. So,
right.
Great discussion.
Thanks, folks. And I really appreciate the theme there, which is a little bit about how do we keep routine or regimen, recognizing how important that is, and injecting those creative solutions, whether that is accessing one's own blood pressure monitor, or as Maria, you mentioned, we have a comment on Facebook actually saying, thanking you for sharing your creative solution to staying active by just going in your driveway and collaborating with your neighbors. Because a lot of folks are looking for some of those creative solutions to, people have been, I suppose, forced to innovate to stay where they were before the onset of the pandemic. And I think that leads into the next question, which is around trying to access really the same standard or form of care, but in a very different medium or very different sort of rhythm over the course of, let's say, a given year. So the next question is, many of us, I live with diabetes myself and have had a pretty shocking shift of how care is delivered. And a lot of us have experience with this, and it's services moving to a virtual format. And virtual doesn't necessarily mean going onto a laptop. It could mean, as mentioned, having an appointment over the phone. It could mean having a blood pressure monitor in the home. It's a means of taking these metrics and mechanisms into a new form of delivery. So I think we can all relate to that. And the transition to virtual care for type 2 diabetes is certainly no exception. So I'm wondering, Dr. Kiran, if you can explore sort of basically what this means. What is underlying virtual care, and what are the different ways that we can really look to provide or receive care virtually?
Yeah, so when I think about virtual care, I think about 3 different modes. So we can think about care on the phone, care by video, or care by email or secure messaging. By secure messaging, I mean, often it's like in a platform where that it's when you're communicating with your doctor, that's not going to be hacked, and it's separate from usually your other kind of personal email. And some people have access to that, but some people it's just sort of regular email, which does have some, I guess, security challenges with it. But when we think about virtual care during COVID, I've described these 3 different ways in which we can think about virtual care, but the vast majority of it actually, from surveys and data we see, has really been phone care. Phone is how most of the appointments have occurred in Canada. And then second would probably be video and actually video and email. And some of the surveys I've seen have been pretty close to each other. It does depend though on your doctor. So it's very doctor dependent whether the doctor has adopted either of those things. And so with phone, obviously, we can talk about how you're doing from an exercise perspective, what's your blood sugar readings been like, what is your blood pressure monitoring like? But there are limitations because I'll say even from a mental health perspective, although we can talk about what your anxiety is, I often find it's actually harder to make that connection and really understand where a person's coming from without seeing them face to face. And so the face to face can be by video or it can be in person. And then, so the things that we also have to look at then that you can't get through the phone often are, I can think about it times when I was in our urgent care clinic and someone with diabetes thought they had a new foot lesion. And so that was when I would then convert and look to video. So I started off as a phone call, hearing about what it is that they were worried about, and then I was like, I can't really assess this unless I see it. And so the 2 options for seeing it are either looking at it via video virtually. So the 2 virtual options, I should say, are looking at it via video. And then the other is actually them sending a picture by email or secure messaging. So depending on a patient's comfort, we would use one of those 2 modes. I would also, so video is really helpful and I often would convert a phone appointment to a video appointment if there's something that I need to see. Email, as I said, it can be useful if somebody, can't figure out the video technology, because sometimes that can be a little bit tricky. Like in some cases for us to use the video technology, I know you can just FaceTime, but in my own institution, they discouraged FaceTiming. I will say that if a patient has, the ability to do that, I'm very open to doing that. But I know some doctors are more reluctant. So there are some more secure kind of ways in Ontario where we can deliver it. For example, called the Ontario Telemedicine Network, but often patients have to download an app and that can be confusing. And so just the whole process of setting up the video is not straightforward for everyone. Sometimes it just works. And then sometimes actually in the video, you can't see the resolution quite as well as you want to. So let's say there is a lesion on the foot and you're looking, and the person can't really adjust their camera properly. So you maybe don't see the right part. And then maybe, it's too blurry for you to really understand, is this spreading redness or is it really defined? So an alternative then, as I said, was the email or secure messaging and sending a photo. And so that's really useful. But I think the other useful piece about email or secure messaging is being able to just dialogue in the absence of a visit. So what we call asynchronous or not at the same time communication. So I could email you at one time and you can respond at a different time. And that's really useful for things like sending blood test requisitions, which is probably the most common thing, but also handouts and links to some really great educational videos. And then I think on the reverse side, patients sending me their blood pressure readings or their blood sugar monitor readings. So in my practice, as I said, I was trying to educate folks about how to do your own foot exam. And so we started to share this handout from the diabetes organization in the UK for something called the Ipswich touch test, or how to keep your feet healthy. So that would be an example of something that I would send by email. I'd often also commonly send the website for Hypertension Canada, which has some really great resources of where to get a blood pressure machine or how to do your blood pressure. So all of these 3 modalities fit in, the vast majority phone, but video and emails certainly have their use. Unfortunately, not all doctors and all healthcare providers are comfortable with video and email, and not all patients are comfortable or have as much access to those 2 modalities either, which limits their use on a wider scale.
And I'll just add to that when it comes to the glucose monitoring piece. So there are a growing number of technologies, both sort of sensor-based technologies, where somebody's wearing a monitor on a regular basis, like a Freestyle Libre or a Dexcom. But even more traditional finger poking blood sugar meters that have a Bluetooth to an app on a smartphone. And so when you get that data on the smartphone, you can connect it through to a clinic account, and the data can be shared sort of once and securely, and then it's just shared, which is really nice because, I mean, in my practice, I see a lot of patients with insulin, and it's almost impossible to adjust insulin medication without good glucose data. And so when those devices became a little bit more readily available at the onset of the pandemic, and the sharing platforms became more readily available, we got a lot of our patients on those sharing platforms. And so that's almost a fourth modality, if you can think about it, where it's sort of sharing or remote monitoring, sharing data with your practitioner. And sometimes we would talk about the data synchronously, meaning over the phone or video. Sometimes we'd even share a screen, and I would show them what I was looking at and show them, well, I see that you tend to sort of dip overnight and then rise, and then when you wake up, and we could talk about what the habits are and what adjustments to medications and activity we need to do for that. And sometimes it could be asynchronously, because they could say, for the last 2 weeks, my glucoses have been running high, and they could email me or another member of the team, like a nurse and dietitian, and ask for some advice on how to manage that. And so, again, I think that's an innovation that became more prevalent during the pandemic that I do hope will stay to help people feel supported in their self-management of diabetes.
I was actually using one of those monitors before the pandemic occurred. So my endo was an elderly gentleman, and he was surprised with that tech when I came in with the graph and everything, and he was like, what is this? But it really helped us because he was able to identify when I was dipping or when I was going a little bit too high, and adjusting my meds that way. And I've tried the Freestyle Libre. My only problem with that is it doesn't last the 14 days. I don't know if it's because of going to the gym, it gets knocked off or whatever. I never get it to last the 14 days, even with those little sticky strips. I've kind of given up on that.
Yeah, it's everyone has to find the devices that work for them, for sure. But I love that you brought it in and you sort of took control and educated your physician, because I think that's a really important part of diabetes that I often say, and Dr. Kiran mentioned this already, like, we spend such a tiny amount of time with our patients, and they have to live with the disease day in and day out and make those decisions about activity and food and medications and how to manage all of that in the context of a pandemic. And so where you learn something and you bring and you share it with us, and then we can then share it with another patient. And that's just a great way to manage as a team.
Absolutely. I really agree that it's really wonderful to see this sort of tables turn a little bit, where Maria, you said, check out this technology and look at all that it can do, and look what it's doing for me. I really like that, changing the direction of how information often flows. The next question that I'd like to pose is to the three of you, and it's regarding, we've touched on what your experience has been like, and a little bit on sort of the opportunities. So I suppose I'd like to hear more, and a lot of folks are discussing this more and more frequently as it becomes more common. But what are the real opportunities and challenges posed by virtual care for type 2 diabetes?
I guess one opportunity is to get care closer to home. Not necessarily, some people have more complex diabetes and need access to subspecialty care, like, endocrinologists with expertise in certain insulin management, et cetera. And that used to be a really big challenge. There's like, at least in Ontario, we have like Northern travel grants. And so, just to come in to see the doctor for 15 minutes, but it was like a 2-day trip to come down from somewhere in Northern Ontario. So I think that while we were doing some virtual medicine for remote and rural communities before, it's because we can now just do it on the phone. It's just a lot more accessible than it used to be. So that's definitely an opportunity that I think myself and some of my patients I've gotten more referrals from more rural and remote communities to help support their care because of the pandemic.
Yeah, I think a couple that I'll highlight. One is I think that just building on Ilana's point, I think if we take an equity lens, there are both opportunities and challenges. I think virtual care is helpful for for some folks, because it means they don't have to take a half day off work to see the doctor. They don't have to pay for parking or transportation or childcare. And so for some people, it actually helps from an equity lens, and helps level the playing field for them. But for other people, virtual care really doesn't meet their needs. And so we've been doing some patient experience surveys in our family health teams that work with the University of Toronto. And what we found in the results is that, most people are very comfortable with the privacy and security of phone and video and email or secure messaging, but some groups are less comfortable. And so it turns out, if you are living with a lower income, or you are new to Canada or have poor or fair health, you're generally less comfortable with the privacy and security of virtual care. And it turns out that those same people also, many people want virtual care to continue afterwards, but people who fit those three descriptors, if they're new to Canada, live with a lower income, or have poor or fair health, they're actually less likely to say that they want those virtual modalities to continue. And so that suggests to me that, the virtual care is not meeting some people's needs. And of course, one of the reasons I often, would bring people in is people who, for example, have hearing difficulties, or who have actually difficulties around access to technology. And so their phone wouldn't be working well. And so it was really hard to actually just have a conversation. And people who have speak a different language, although I could get a translator on the phone, there are many people for whom they speak enough English that if you meet them in person, the conversation is fine, but somehow when you get on the phone, it's actually a lot harder for both parties to understand each other. So I think that there are both opportunities and challenges with virtual care. So we have to be conscious to still offer the in-person appointment for those people who need it, at the same time recognizing that virtual care helps other people. So I think that's like one piece. And I guess the second opportunity and challenge I'll just put out there relates to what things that we've just talked about, which is, the opportunity for people to take even more control of their conditions. So that means that, some people can, now feel much more comfortable with self-assessment than they did before. And I think this really works for people who are, ready to take that role for themselves. Unfortunately, there are some people who I think still look to their doctor a lot for that kind of thing, or for whom like their life is just so chaotic, it's hard to focus on the diabetes. And so those people might get left behind more from a virtual care perspective. And I think Ilana kind of alluded to that with some of her cases that she brought out, that some people have kind of just not gone in for their diabetes check in a long time. And I know, Maria, you kind of mentioned you didn't have lever, but you were still connecting with your doctor, and you were conscious and doing your blood sugar levels at home and stuff like that. So I would say it's more just like people who there's like going to almost be a divergence. Some people who have even more skills in self-management, self-assessment, and then others who just kind of stayed where they're at.
For myself, I am so happy with virtual care that I can go see my doctor, my endo, maybe once a year, because I think I used to go twice a year to go see him. Now I'm good with just once, or just continue this whole virtual care business.
And I think what Tara talked about that's so important is choice. Is that what we're hearing from, as in the first and second wave of the pandemic, it was really about keeping everyone safe, including the healthcare practitioners, right? But it really shouldn't be about that part anymore. And that people who are comfortable coming in should be able to come in, and people who would like to continue to get their care virtually should. But like I've said, there are some patients where I ask them to come in and they still turn it back to phone. I sort of say, I really was hoping to see you this time because I really want to look at those feet, but have you looked at your feet and are you concerned? And better that we could connect and at least do maybe probably 80% of what I could do over the phone forever. And it's that 20% of in-person that I would like to be able to do, and that will work in that sort of post-pandemic environment, sort of a once-a-year in-person visit. Yeah, I agree. I think we need to put choice at the forefront and equity at the forefront in terms of the way we offer different access, phone, video, in-person, secure messaging. It really has to be what's going to work for the patient to feel confident in managing their diabetes.
I think one other point I'll just raise as well, which builds on other parts we've discussed, is I think I'm often conscious that people are having different experiences based on their physician and their physician's comfort level with things. And I think that's something that as a system we need to do more to address. I think every physician is comfortable using the phone, but certainly not video or email secure messaging. And some of there are some systems barriers. So, you know, if we want to, like sometimes if we want to integrate video within our own electronic medical record in a very seamless way, we actually have to pay more fees to the vendor for that feature. If we want to integrate secure messaging into our, you know, to make it seamless within our workflow, again, that is another fee that the office kind of has to put up. And I think, you know, we need to move to a model where those are standard features of our electronic medical records, that there are standard ways that we're getting trained on that. You know, as when we get trained as a doctor, we're getting trained in how to conduct an in-person visit, not on like email etiquette and like how to build your practice in a way that email can be part of it. Yet we know that when, you know, studies have been done and we offer people things like video and email, actually the asynchronous messaging, or that means like being able to message with your family doctor at different, so you're messaging a different time than your family doctor messaging, that kind of communication is what people really like because it's super convenient and often can prevent a visit. But that kind of thing has not been integrated into our workflows, and we haven't really helped all our profession come up to the same level to use those. So I do think that's an opportunity that we have to build on. It's kind of funny when we talk, I find when we talk about virtual care that we're just like talking about the phone, basically, which is a technology we've had for decades.
Yeah.
That's a really good point. The how ubiquitous the phone is. It's really not that unusual to be accessing care this way. It's, you know, Alexander Graham Bell would recognize what we're up to. So you know, I think that's a really excellent point. So folks, thank you for those perspectives. And I now we'll open the floor to some questions that we've been receiving, and like to say thanks to everyone who has been submitting questions over the Facebook chat. And if you have anything else you'd like to hear, please feel free to add it now. The first is sort of a trio that I'll package together, and it's specifically around a change in basically blood sugar trends, blood glucose trends that folks have been undergoing, and they're wondering what the connection might be between stress and lifestyle changes and this happening. So first person is stating that they're over the course of a year, they've gone from an average of around 6 to 7.5. And all else being consistent, food and exercise. They're saying food is the same, thinking if this is stress. Another person with essentially the same question. They were running consistently from 7 to 8, and they're suddenly up in the 9 to 10 range. And then another, yet again, the triplet in this trio of questions is before COVID, their hemoglobin A1C blood work results were very, very good between 7 and 8. But in July this year, it went back up to 9. So again, just wondering, all else being fairly consistent, what do you think is the culprit here? Recognizing you folks don't have access to the in-depth data, but maybe it's a chance to speak to the impact stress has had in what you've seen.
So yeah, I mean, I have two initial thoughts. One is that stress definitely impacts blood sugars, and sometimes just being able to help people understand that in real life is like helps to alleviate that stress, because it's a bit of a chicken and egg. And if you're doing self-monitoring, but even if you're not, and then you just go and you see that your A1C is way higher than it has been in the past, and you get more stressed about it. And so we know that physiologic stress, whether it's because you're fighting an infection or because there's a lot of, you know, external stressors in the world today, will raise a lot of your stress hormones like cortisol and adrenaline, and those things actually cause your blood sugars to go up. Another thing that is very closely linked is sleep quality. So if you're not sleeping well, then you tend to wake up with higher blood sugars, and that will impact the whole day. But the other thing that I think is always important to mention is this pandemic has been going on for a while, and diabetes is a progressive disease. So it may have nothing to do with the pandemic, and it's just that over time, despite the same amount of activity and diet and similar all lifestyle things being equal, the pancreas poops out. Your pancreas is already sort of pooped out when you get diabetes in the first place. And then there's a lot you can do to support it, But sometimes you just need to look at other new levels of medications, different ways of treating things. So, and I like to tell people that so that they don't feel like they've done something wrong. This is who you are, your genetics and whatever other environmental factors gave you diabetes in the first place, and it is common that over time people need to add on medication. Those are my two thoughts when I hear that kind of recurrent theme. Yes, stress plays a role, but also 18 months has passed, so.
I can relate to that because I noticed that my blood sugar spiked to numbers I hadn't seen since the beginning of my diabetes journey. And my doctor was like, I called saying, my numbers are crazy. I think I need insulin. And he was like, Maria, are you sure about this? I'm like, I think I need insulin. Like the numbers were 22. I reached 22 at one point. But I knew it was stress. I was doing everything else the same. I intermittent fast, everything else was the same, except the stress factor was on because I kept my family like prisoners in the home. They couldn't go anywhere. We were like, it was crazy. And once he got me on the insulin and then the stress left like this year with the vaccine, whatever, I start noticing the numbers start coming down. And now like the insulin is, unless I'm eating something really high carb or something like, that's the only reason I would have to use that. So I can totally.
That's a very common story, Maria. And we have other reasons why people might need insulin temporarily because they get added, another medication gets added that spikes up their blood sugars, et cetera. Right. Really important message because a lot of times when people hear the word insulin, they think it's forever and always, and they get very frightened. But for people living with type 2 diabetes, that's not necessarily the case. But it can be a very helpful tool when things feel like it's spiraling out of control.
Yeah.
I think the other thing that I'd just like to build on too is just like how exercise and diet has changed for many people over the pandemic. And I think many of us might think that we haven't changed our like exercise or diabetes that we're doing, exercise and diet, but actually they have changed because of some of the nature of our habits. So, if you're doing a lot more working from home, for example, that means that you're not taking those steps to like commute to work. That you might have, and you're spending a lot more time being more sedentary in one place. You're not even walking to different offices to have meetings with people. And so, maybe you're still doing like the one workout a day of 30 minutes, like on a treadmill or whatever. But and I know exercise in general has been hard for people with gyms closed and all of their restrictions. But let's say even if you were able to do that same kind of workout a day, all of those other pieces in your day are different. And so it may overall be like you're doing, for example, less steps and you're more sedentary than you have been in the past without even totally realizing it. And then I think the other piece relates to also the diet. Like similarly, if you're working from home, I know for me, it's like really tempting to go down to the kitchen and like just take a snack, whatever, just because it's there, the food is there. Whereas when you're working in the office, often those types of things are a lot, they're more structured and a little harder to get to. So, and then I think also when, many of us are stressed, we're sometimes stress eating. So I think those factors, even sometimes you don't necessarily think that your breakfast, lunch, and dinner are different. Obviously, there can be these sort of small changes that can have bigger impacts as well.
Thank you, folks. We have another question that is from someone who's fairly recently diagnosed, and they say they're still in the learning curve. The question they have is, when they check their blood sugar and the reader says, for example, 6.9 after a meal, they're wondering, is that a good number? Is that too low? Does that mean if they have something that's worth 4, would that become a 10? Wondering how they figure out how much room they have to eat something else.
You should do that one, yes.
I also want to hear what Maria has to say. So, I think that, there's a lot I don't know about this person in terms of medications, et cetera, right? So I think the big one is sometimes people who are living with diabetes are worried about something called hypoglycemia, which is a low blood sugar. But you don't really need to be worried about worrisome or dangerous hypoglycemia unless you take insulin or a medication that makes your pancreas make more insulin, like glyburide or gliclazide. If you're not taking those medications, you don't have to be too worried that a number is too low. because it may be normal for you that day, and you may feel a little low if you go from over 10 to 4 very quickly. So let's say you went for a run and you burned out a lot of that glucose. You may feel low, but you're not going to get to like sort of a hypoglycemic seizure or coma or anything like that. It's really only when we introduce medications like insulin and glyburide, glucoside, that we have to be worried about that. We generally talk about the target glucoses after a meal being up to 10. And it's normal if you check your numbers a couple hours after the meal for it to go up. That is a normal response. Even in somebody who doesn't have diabetes, there's going to be a slight increase. It's just that when the pancreas is working totally properly, it more is like stays in that kind of 4 to 8 range most of the time. And so a 6.9 after meal is a fantastic number. And can you eat more? Sure. Do you need to eat more? Maybe not. So I wouldn't eat to your numbers. I would eat to your hunger, to your fullness, learn a bit more about intuitive eating. One of the nice things about checking numbers after meals, which people don't always do, is you get to learn what the difference is between, having, if you think about the plate method and you have a quarter of your plate be carbohydrates versus if the whole plate is carbohydrates, you're going to see a different number. And if you eat that whole plate of carbohydrates, but then you go for a nice 20-minute walk after the meal, you'll also see the impact on your blood sugars. So that's great that you're checking. A lot of people think that people who are early diagnosed don't necessarily need to check. And you definitely don't need to wake up every morning and check every morning and you always have a blood sugar of 6 to 7. Like, that's not a useful tool for yourself or the doctor if you're consistently always have a good fasting sugar. But learning to check as a teaching, a self-feedback tool to say, what does this type of exercise and what do these types of foods, and as I adjust my medications, what are my numbers, gives you a lot more of an understanding of how your body's responding to these different factors. So that's, I think, a helpful tool to use.
Well, when she said the 6.9, I was like, that's a good number. I wouldn't necessarily continue to eat, or if you have to have something with a protein in it and a salad. Sometimes that's my trick thing. If I think I need to eat some more, I have a vegetable of some kind or a fruit, like a low glycemic fruit. And that usually helps me, or I fill up on water. That's also very helpful.
We have someone else that's curious about, to the mention earlier of checking one's eye health. They're curious if that has to go through an ophthalmologist.
So actually, it doesn't. You can see an optometrist, and if you have diabetes, that should be covered by OHIP. Or I know this is a national webinar, but I think that in other provinces that would be the case too. So at least in Ontario, if you have diabetes, you're able to see an optometrist, and that's covered under the health insurance plan. What's tricky is that in Ontario right now, the optometrists are kind of working to roll. And so since September, they are kind of protesting the government's sort of not increasing the amount that they get paid for certain types of exams, by refusing to see people who OHIP would pay for, which is unfortunate because it is really some of the people who wouldn't be able to afford to see the optometrist otherwise. So right now, unfortunately, people with diabetes are like caught in limbo in Ontario when it comes to seeing an optometrist. But I'm hopeful that that's not going to last for very long. And in usual circumstance, an optometrist is a wonderful choice for screening. And in fact, it's not a good use of an ophthalmologist time just for a screening routine eye exam. If something is identified that needs to be addressed, that's when either the optometrist or the family doctor can refer you to an ophthalmologist.
And I have found it's a bit hit or miss, the work to roll thing. I certainly still had patients being seen by their optometrist. So it's, this is the reality of healthcare in general. You don't know until you try. But I would completely agree with what Tara said. It's that the optometrists are trained to do that screening. It's much easier usually to get an appointment with an optometrist than it is with an ophthalmologist. And so let the optometrist be your first line of defense. And if they see anything that they're worried about, they are able to pass you forward to an ophthalmologist who could potentially do something about it.
Yep. Thank you, folks. We have a similar sort of vein of question, which is someone that was told at a diabetic workshop that an annual visit to the podiatrist is free, and they're wondering because they went and were charged $150. So I will add sort of the caveat that this will vary depending on what province or territory you're in, what your provincial plan looks like. I know we have some resident OHIP experts, but I would check into what your province is actually all about.
Yeah, so in general, go ahead. No, go ahead, Karen.
Yeah, in Ontario, unfortunately, it's not covered, and I suspect it's the case in most provinces where the health insurance plan won't cover foot care from a chiropodist or podiatrist. Obviously, family doctor care is covered, and so some family doctors work with nurses. Like we have a nurse in our team who does support foot care. So if you're lucky to be in a family doctor's office where they provide that kind of service, that's one way to access it for free. And then there are also some training centers that offer low cost or free foot care to folks as well. So if you're looking for, if you don't have an insurance plan that covers it and you don't feel like you can pay for it out of pocket, those are a couple of options.
Yeah, that was what I was going to recommend. Is I know when I have patients who can't afford it, I usually send them to, at least here in the GTA, the Michener Institute is the one that's doing most of the training for chiropodists and podiatrists. So obviously, depending on where you're living, you may be able to access some care that way. And Diabetes Canada has local chapters where they try to help people sort of navigate and know what resources are available to them. And there is always that phone number you can call, and Brooks can tell you more about, to help you navigate some of that stuff, because it is a real problem. I mean, we could talk a lot about the fact that we live in a universal healthcare system, but medications are not universally covered, devices are not universally covered, and a lot of this preventative care is not universally covered. And so we know that that's an ongoing challenge for people living with diabetes, and that's why if there's resources like Diabetes Canada to do their best, they can't necessarily fix all the problems, but help you navigate this complex system that we live in Canada.
Yeah, that's really point well taken, Ilana, point well taken. And I think I'll add the plug that if you would like to get put in touch with resources, you can call 1-800-DANCING or visit diabetes.ca or email info@diabetes.ca. And it's a big part of a lot of our advocacy initiatives is making sure that as many people as possible have access to the treatments that they need, but also in the meantime to direct people the right way within the system. So thank you for that. Another question is regarding a person that's their doctor hasn't been available for in-person consultations. They've had blood tests periodically and have a glucose monitor at home, but they're wondering about self-monitoring for symptoms of kidneys, feet, other complications that they should keep an eye out for.
So one thing that I would just jump in to say is that I think it's worthwhile just checking in again with the doctor because things are changing. And sometimes some doctors are still working on what's called a virtual first model where they want to talk to you on the phone first. And then if there's a reason to bring you in, they will bring you in. I've been encouraging all of my colleagues to move away from that kind of model now, given that we have very high vaccination rates and generally good access to personal protective equipment as physicians. So my hope is that most physicians now, and much of the data shows this, is that the vast majority are seeing some people in person. But I think sometimes the way their message machine conveys it, or maybe that the way the receptionist conveys it might be different than that. So grab a phone appointment with the physician though then and tell him or her why you might want to come in person. So that's just, Ilana, maybe I'll turn it to you or Maria to answer that other piece, but I just wanted to flag that part.
Yeah, no, I completely agree with what Tara's saying, and I think that there's a lot of, in general, we know access to primary care is challenging, and so people will call and they won't get an actual person on the other line, and the voicemail still says we're not seeing people in person, but like if you actually talk to your doctor, they will bring you in. We know it's not always so easy, and that's certainly the approach I've been taking in my endocrine practice for at least the last 6 months. In terms of symptoms, kidneys is a really tough one. You don't tend to have symptoms of kidney dysfunction until it's quite advanced. But if you start to get swelling in your ankles, difficulty breathing, some shortness of breath, just like a really bad sort of fatigue and unwellness, then so it's really not specific. that could be a sign that your kidneys are not clearing. In general, people say, oh, my kidneys are at my back. If I have a low back pain, is that my kidneys? Almost never. Unless you have a kidney infection or a kidney stone, your kidneys are not going to cause you pain from a sort of what we call diabetic kidney disease. Feet, Tara already spoke about, there's a lot of great things. You can call it like touch the toes test is the other term for the Ipswich test, and you can find it on the Diabetes UK website, and it's a great, you need a partner at home to do it for you because they have to be touching your toes and seeing if you feel it. If you're having like nerve pain, which feels more almost like your foot's asleep, or you're having like pins and needles in your toes, that could be a sign that maybe you're experiencing some neuropathy related to diabetes. And of course, the big stuff that you hopefully have seen, the heart and stroke types of commercials and things like that, it's any sort of chest pain, shortness of breath, stroke symptoms, or you're having difficulty breathing, sudden loss of vision, anything like that, that's a straight to the emergency department type of symptom. That really, in the first wave, we saw people staying at home with those types of symptoms for too long. And my colleagues who work on the inpatient side of medicine were seeing a lot of people presenting with disease later because they were afraid to go to the emergency department. So I hope that answers the question about what sort of symptoms to monitor for while you're at home. But I think the most important message is if you're worried about your health, your doctor wants to look after you and you should seek care.
Brooks, I added a couple of things to our chat, and I don't know if you're able to add it to the Facebook Live.
Yeah, we can. Thank you.
That might be helpful.
Thank you, Tara. We'll get those in the Facebook chat as well. Folks, recognizing we do unfortunately have a hard stop. This is such a great conversation and really great to keep people's questions being answered in real time. I know we have a hard stop at 5 p.m. Eastern, and I want to just field two questions that are pretty personally tailored, and I think could really benefit from having a tailored answer. So these questions are from a viewer who is on a maximum amount of oral meds plus Ozempic, and I think next step is insulin. Their A1C is consistently 8 to 9. They can't see their endocrinologist until December, and they're wondering what they can do to get this A1C down. So that's question one. And the second one is someone who's calling from or watching from Victoria, BC, where there is a critical shortage of GPs. Their own doctor is on medical leave, so they don't have a doctor, and they're feeling very much on their own with type 1, and it's getting worse. Their A1C is increasing, and they can't see an endo until December. So wondering what they can do and feeling desperate.
Oh, I feel so badly for both of you, although I know that many of my patients can't see me until the new year. So I guess my answer to that is the system is struggling, and individuals are struggling because of that. For the first patient, I would say, is your primary care practitioner comfortable starting insulin? A lot of primary care practitioners are comfortable starting basal insulin. Does your endo work with the diabetes team? And even though you can't see your endo, maybe your endo can at least speak to the nurse and prescribe a starting dose of insulin so the nurse could get going on it. So those are my thoughts. I think it's great that you've identified that you've sort of maxed out all the other options and it's time to start some insulin. December is not that far away in the grand scheme of things, but if you're really motivated, those would be two channels that I would recommend in terms of getting started on the insulin. I don't have a good answer about not having access to any sort of primary care in Victoria, except to say that I think there's a move afloat, especially as it comes to virtual care, to start thinking about providing care across provincial boundaries. It's still very complicated. Our licenses don't cross provincial boundaries right now. And so it's really, the CPSO says I'm only supposed to provide care to people who are in Ontario unless it's a crisis and they absolutely can't get care somewhere else, and then I could provide virtual care outside. So I don't have a great answer to that. I wonder what Tara thinks.
Yeah, it's always so hard to hear from people who can't find a family doctor, but I'll say I've encountered the same thing with my own patients who've moved away from Toronto, and I'm continuing sometimes to refill their meds and be their doctor because they haven't been able to find a new one in their new place. So I guess I have a few suggestions. So the first would be, in some provinces, there are centralized pathways to finding a family doctor. So in Ontario, there's something called Healthcare Connect. Quebec also has a centralized pathway. A few other provinces do too. I don't think British Columbia is one of them, but if you're in a province where that's the case, you can use that. The second is that often connected to a medical school, there are training centers. And so find out so UBC has a medical school and they train family doctors, and they're family doctors who are trained in Victoria. And so you can try and figure out which of the clinics is a teaching clinic. And oftentimes the resident physicians at teaching clinics are growing their practices or looking for some new patients. And so you could approach a teaching clinic. And then of course, the third is unfortunately not a great one, but there are obviously walk-in clinics. They're both in-person and virtual clinics that you can use. And, I think that, it's not optimal because we know that continuity of care is really important, especially if you have a chronic condition, but it's better than no care. So if you aren't able to find a provider, one of the other two ways, then that's the case, then you can use that. I will say, I think there's a move to more team-based models in the island of Vancouver. So of course, also hopefully keep your mind open to seeing a nurse practitioner, if that's an option, because it doesn't necessarily have to be a family doctor that you have.
The only thing I can
recognizing.
offer. Sorry, Brooks, go. I think we have like 3 minutes or something. But what I was gonna say, and I ladies, don't jump on me. What has worked for me to bring my A1C level down was intermittent fasting. I know there's some controversy about that, but that has actually worked really well for me to help me manage my condition. So you might want to.
Yeah, I definitely wouldn't jump on you. I think any approach, lifestyle approach that works for patients is great. I only caution those who are using insulin or those other medications I mentioned and doing intermittent fasting, that you're monitoring your sugars frequently and you know what a low blood sugar feels like, and have some support to adjust your medications if needed.
Right.
Yeah, good point. Great point, both of you. Keith, I think that importance of being a bit creative in how we solve problems, as mentioned earlier, is really important. So folks, we do have a couple of questions that unfortunately will not be able to answer with the time limit of 1 hour, but those questions are around numbness in feet, how often a person should be checking throughout the day, and specific types of blood glucose monitors. So for those questions, I can confidently say they are all, we're very well equipped to answer those at the Diabetes Canada info line. So please feel free to check our website, or B, reach out to 1-800 Banting, as mentioned earlier, our info line, or to email info@diabetes.ca, and our team will be happy to direct you the right way. So with that, we do have to come to an end, but I just want to say a sincere thank you to everyone who viewed and submitted questions. It was a really, really thoughtful discussion, and especially, of course, to our guests. It really meant a lot to have your input, Maria, Ilana, and Tara. It was really fantastic conversation. I know personally, I gained some knowledge out of this, and I hope that everyone viewing did so as well. So I'd like to say a sincere thank you and assure everyone, as mentioned, Diabetes Canada is going to keep working to make sure that these questions are not only answered, but answered with better answers, where it's more satisfactory how resources are available to you. So thank you all. And again, please don't hesitate to reach out to Diabetes Canada if you have questions, and we'll do our best to steer you in the right direction. So to our guests, thank you again, and take care.
Thank
you so much.